to approach Cushing syndrome. I'll be talking about the symptoms of Cushing syndrome, how to identify it, and how to work it up, including how to differentiate between the causes of Cushing syndrome. So let's get started. First, Cushing syndrome is a disease of chronic or prolonged hypercortisolism. It's a disease of excess cortisol. There are a number of causes of Cushing syndrome. I've listed some of the common ones here. It can firstly be iatrogenic. Essentially, patients are prescribed cortisol or corticosteroids for a number of reasons, and if they have them in too high of quantities for too long, they can develop Cushing syndrome. So that's iatrogenic. They can have hypersecretion of ACTH from a pituitary adenoma. Remember, ACTH is the hormone that stimulates the adrenal glands to produce cortisol. So that would be Cushing's disease. They can have adrenal cancer, where they have an adenoma in the adrenal glands, or a carcinoma in the adrenal glands, that essentially secretes a lot of cortisol. They can lastly have adrenal hyperplasia, and that could be secondary to ectopic ACTH or ectopic CRH production. And there's several cancers that can cause this, most notably small cell lung cancer, that is pumping out ACTH, and that causes the adrenal glands to become big and secrete a bunch of cortisol. So I'll also review the HPA axis to get a better understanding of how these are different from each other. So this is the whole algorithm if you just want to study it and learn it. Otherwise, stick around and listen to me talk about it. So first, a patient will present with signs of Cushing symptoms. So what are these Cushing's syndrome symptoms? Here's a good picture that kind of highlights them. Some of the good ones, or some of the ones that are unique to Cushing syndrome, are outlined with the SARO, so glucose intolerance, because Cushing syndrome has kind of an insulin effect. Cortisol has somewhat of an insulin effect. The moon facies is pretty characteristic. They'll have a wide, round facies. Buffalo hump, thinning of the skin, fragility. Essentially, they're wasting, I think is a good term to describe it. They can have excessive hairiness or hirsutism, especially noticeable in women, and they can have abdominal striae from stretching of the abdomen and from thinning of the skin. So those are characteristic signs of Cushing syndrome. So a person comes in and they look like this with these features. What do you do? First thing you do is you want to get a 24-hour free urine cortisol and a low-dose dexamethasone suppression test. The low-dose test is 1 milligrams, and it's important that you get the 24-hour free urine cortisol because your cortisol levels fluctuate pretty wildly throughout the day. So if you get just a morning dose or just an evening dose, it's hard to assess what's normal based on that single measurement. So the 24-hour kind of averages out that varying cortisol level. Now, if you have suppressed cortisol, if you have low cortisol after 24 hours of collection, and if you have a normal result for the dexamethasone suppression test, then you are unlikely to have Cushing syndrome. Remember, this is the HPA axis. So in the hypothalamus, sorry to deviate a bit from the algorithm, but I think this will help us understand it. In the hypothalamus, we secrete CRH, which is corticotropin-releasing hormone, stimulates the anterior pituitary to secrete ACTH, which is adrenocorticotropic hormone, and that stimulates the adrenal cortex to release cortisol. Cortisol feeds back on both of these. So cortisol inhibits production of ACTH and also inhibits production of CRH. So there's feedback loops all around this. The idea is that if you have a normal result in the dexamethasone suppression test, now I should explain this, dexamethasone acts like cortisol, and in a normal healthy person without Cushing syndrome, we would expect dexamethasone to reduce the amount of cortisol in the body. So dexamethasone will negatively inhibit the CRH production, the ACTH production, which downstream will reduce the amount of cortisol. If that's the case, that's a normal result, less likely to be Cushing syndrome. If it's not the case, and a person still has excess cortisol after dexamethasone suppression, then we suspect Cushing syndrome. So this result was not Cushing's, this result was suspected Cushing's. Now, next step if you suspect Cushing syndrome is to measure the plasma ACTH levels. Let's go back to our axis here. If we measure the ACTH levels and ACTH is low, that means that the problem isn't here. If the problem was in the anterior pituitary or any other ACTH secreting tissue, ACTH would be high. So let's kind of carry this algorithm forward. If the ACTH is low, then we suspect the problem is with the adrenal glands. We suspect an adrenal tumor. This is kind of an easy outcome because all we have to do is confirm that the tumor is in the adrenal glands with a CT or MRI, and we can resect that tumor. If, on the other hand, the ACTH is high, then we know that the cortisol production is because of the high ACTH, because the adrenal cortex is doing what it's supposed to be doing. It's responding to ACTH and creating cortisol. In that case, we would suspect extra-adrenal tumor that is creating the ACTH. So this is an ACTH-dependent Cushing syndrome. Now, it's extra-adrenal tumor, but that doesn't necessarily tell us that it's in the anterior pituitary. Remember, I told you there are other tissues like small cell lung cancer that can produce ACTH. So we do now need to differentiate where the ACTH is coming from. One way to do that is with the high-dose dexamethasone suppression test. So the high-dose test, this is a pretty high dose now, so we would expect that this high-dose test does negative feedback on the anterior pituitary. So even if you had a pituitary adenoma and you did a high-dose dexamethasone suppression test, you would expect the cortisol to be suppressed, and that's the outcome that we see here. If the high-dose dexamethasone suppression test suppresses the cortisol, that's Cushing's disease. That's ACTH from a pituitary tumor. The anterior pituitary has a tumor, and that tumor is producing ACTH. It doesn't respond to low-dose dexamethasone, but it did respond to high-dose dexamethasone. It still has some properties of the normal anterior pituitary. In this case, you would confirm with MRI and you would respect it from the anterior pituitary. If the ACTH, the high ACTH level, did not respond to the high-dose dexamethasone suppression test, that means the cortisol was not suppressed. That means that the tissue creating the ACTH was not the anterior pituitary. It was some erroneous tissue that isn't even responding to high levels of dexamethasone. In that case, you would suspect ectopic ACTH production, like pancreatic cancer, like lung cancer. And you would want to do imaging studies to confirm that. So you want to do imaging studies of the abdomen and the chest to localize the ectopic ACTH production. So this is the algorithm. Once again, this is the last slide. Just run through it real quickly. Somebody presents with the Cushing syndrome, moon facies, abdominal striae. First thing you do is get that 24-hour free urine cortisol and the low-dose dexamethasone suppression test. If those are normal, then it's not Cushing syndrome. If they are abnormal, you suspect Cushing syndrome. First thing you do is the ACTH levels. If the ACTH is low, you suspect it's an adrenal tumor because the problem isn't the anterior pituitary, the problem is the adrenal cortex. If that's the case, you can just confirm it, resect it, remove the erroneous adrenal tumor. If the ACTH is normal or high, then it's either the anterior pituitary that's the problem or some exogenous ectopic source of ACTH. You differentiate those two using the high-dose 8 mg dexamethasone suppression test. If those work and they suppress the cortisol production, then you know that the tissue still behaves kind of like the anterior pituitary. Confirm that it's the anterior pituitary and you can remove that surgically. If the high-dose dexamethasone suppression test does not do anything, then that kind of confirms that the ACTH is coming from an ectopic source. Could be pancreatic cancer, could be lung cancer. Find out where it is using CT or MRI of the abdomen and chest and remove that ectopic ACTH production. That's the approach to Cushing syndrome. Thank you for listening.